Now, we'll move along. And look, I'd like to introduce our next keynote speaker, who is Professor Jeff Harmdorf. I think if Jeff is online. So Professor Harmdorf is an academic surgeon specialising in upper gastrointestinal and bariatric surgery, based at the University of Western Australia and Hollywood Private Hospital in Netherlands, Western Australia. He's the inaugural Professor of Medical Education at the University of Western Australia, UWA, and is the Director of CTEC, which is really a world-class skills training centre, and is the UWA's Professor of Surgical Education. Over an extended period of time, he's been influential in teaching, curriculum development, summative assessments, and student progress. At the postgraduate level, he's been involved in education of trainees through simulation. He's been awarded the membership of the Order of Australia in 2019 for services to medical education and surgery, and particularly in bariatric surgery. Professor Harmdorf is the founding partner of the Indonesian Clinical Training and Education Centre called ICTEC in Jakarta. And in fact, the reason why he's not online is that he wasn't able to present live today, and we're going to present with a pre-recorded presentation from Jeffrey. Thank you.
Good afternoon. My name's Jeff Hamdorf. I'm coming to you from Perth in Western Australia, and I'm on the land of the Whadjuk Noongar people as the traditional owners, where I'm at by the University of Western Australia. The Whadjuk people of the Noongar nation remain the spiritual and cultural custodians of their land, and continue to practice their values, languages, beliefs, and knowledge. Thank you for inviting me. I'd like to thank also particularly David Rengia and Hari Bandi for your warm invitation and welcome today, and of course to Tess, who seems to do most of the heavy lifting for you, I think. I'm talking to you today about surgical simulation. I think I have fairly typical disclosures for an aging surgeon, but my role is that as a private surgeon in upper GI and bariatric practice, but more importantly, I spend most of my time at CTEC as the Professor of Surgical Education. CTEC stands for the Clinical Training and Evaluation Centre, based at the University of Western Australia on the banks of the Swan River, or Derbyl-Yerrigan. I also happen to be the president of ANSMOS, the current president of our Binational Surgical Society for Obesity and Metabolic Surgery. I have a role in patient blood management at the national and international level. And I sit on a standing committee for the Australian Medical Council and have a little bit to do with the College of Surgeons and its activities. I'm going to talk to you predominantly about our surgical simulation teaching and training through CTEC. I'd like to offer you some examples of the various courses that we offer and how technically we provide simulations of operative behaviours and situations. I'd like to talk a little bit about the role of simulation in skills acquisition, and then about assessment, and trying to bring it all together towards the end, making some sense of how simulation can fit in its current format. For those of you who haven't been to Perth and to CTEC, well, CTEC, as I said, is on the grounds of the University of Western Australia. It's a purpose-built facility. We celebrated our 21st birthday in April of this year, and we run lots of short courses. And in terms of half-day courses or educational sessions, we would run perhaps 400 per year, and generally have up to 3,000 people through. For us, it's all about promoting safety. I have to tell you, if you happen to get a Monarch opening a facility, there are lots of people wanting to turn up and lots of people very supportive of you. CTEC remains busy. This is a snapshot from 2019. Notwithstanding that 2020 was a little disappointing. But 2019, we had over 2,500 participants through, held 150 discrete workshops, had 275 faculty members through, and we generally rely on them attending and teaching in a gratis capacity, which is what we expect of surgeons. Our participants generally come from Australia, and we seek to recognise everyone who teaches with us. Downstairs at CTEC is our surgical lab. It's a very big facility. We have 10 full operating tables there, lots of supportive equipment, and it is a cadaver lab, although the majority of our courses are not cadaver based. Upstairs is a medium fidelity simulation suite, which allows us to multi-purpose and multitask into different sorts of theatres of activity, if you like. And this is really about teamwork. And perhaps those of you who know about the EMST or ATLS course, it's the ideal venue for courses such as that, EMST and CRISP and the like. So skills laboratories have come about because of drivers for change. So if we look at the drivers for simulated skills teaching and training, we find in the wards that there's decreased time available for dedicated teaching and learning. Our patients seem to be less available to be taught upon. The procedures are increasing in number and of course in complexity. Because of that, I think the training risks are increasing, and with this, patients and society are less tolerant of errors. And this produces a gap which simulation can adopt. When I and many of you were growing up, surgery was about the art and craft of surgery. We had the culture of surgical activity, and it was ward-based teaching. Now, we're accountable, we follow evidence basis wherever we can, and teaching is high tech and a high cost. And often we find ourselves working in skills labs to shorten the learning curve. This represents a paradigm shift in the way that surgical training can, and in many cases is delivered. But in order to do that, you need to have a sustained suspension of disbelief. These participants know that they're not in the ward, they know that they're not in the operating theatre, but if the situation is realistic enough and authentic enough, if the instruments are authentic, if people behave in the way that they behave in theatre, then we adopt what we call the sustained suspension of disbelief. We know that this reduces risks, it improves the learning curves, it allows for practice in a safe, unhurried atmosphere, and allows feedback to be offered straight away. And the next step, of course, is we can then assess people for their technical proficiency in this laboratory setting. Now, that doesn't, of course, that doesn't translate to professional competence, but it's one piece in the puzzle there. So the courses we run, lots of different courses, and broadly speaking, for nurses, we tend to run teamwork courses. In the medical setting, for students, we'll run some pretty basic introductory courses, and then a range of different levels of courses for trainees and beyond. And I must say, we have lots of different courses available in our calendar. If you happen to be a medical student at our university, the first rectal examination you're going to be will be under the supervision of a surgical fellow or a colorectal fellow on a model which has interchangeable prostate parts in it. And so that's a nice introduction to rectal examination. Suturing, we start out using animal substrates, either pig's trotters or pork belly. And patients learn, or the students, sorry, learn using that model. Gowning and gloving, it seems that our hospitals are less tolerant of students learning there, so we teach that at CTEC on a student orientation day. And equally, theatre etiquette is taught using a mannequin, and we invite our theatre nurses along to teach that on our behalf. As we move up the ladder a little, Western Australia and the other states of Australia have GPs doing lots of interventional procedures. So there's a really big appetite for what we call our cutting edge. And so introductory courses, kind of basic skills, moving up to some fairly advanced stuff. And these arrangements are based on training needs analyses that we've done over the years to work out what people want. And I have to say, these are very well supported. If you're an endoscopy trainee or a gastroenterology or surgical trainee in Perth, you'll do your first scopes at CTEC. We have introductory courses in colonoscopy and bleeding, endoscopic ultrasound. Our nurses learn the anatomy of an endoscope and scope processing and reprocessing at CTEC. They come back to practice on some of our mannequins as well. The master classes or advanced classes tend to be the jewel in the crown for many simulation centres, and we run many of these cadaver-based ultrasound courses for our anaesthetists, and these are booked out months and months in advance. Some advanced vascular courses, interventional pulmonology and the like, and these are fairly challenging courses to put together because they're fairly demanding in terms of kit, but they, as I say, they tend to be the jewel in the crown. As an academic institution, I run a Masters of Surgery program as well, which is research intensive. It has some skills units associated with it. It benefits CTEC in producing research, and also the Masters students tend to be our tutors on some of our more basic courses as part of their coursework pertains to them learning how to teach. No, we find that really quite valuable. Now let's move on to our trainees, or perhaps we'll start with our pre-trainees, our JDocs. We've set up some courses, 4 single-day courses, each of which articulates with the framework that's proposed by the College of Surgeons. I've put the asterisk against our accreditation because I think the college has put a moratorium on accreditation at the moment while it's reviewing its accreditation processes. We run an exam preparation course, and we held that virtually this year and had, I think, 65 or so participants across Australia, New Zealand and into Southeast Asia for that live interactive course. We run a bit of professional development for the junior doctors as well. The trainee courses, I think these are the most fun, a whole series of foundations courses. But once our trainees are onto set, that's when they come along and do core skills courses. And the core skills courses, really, we seek to address and provide a nexus to the college curricula, and we articulate these with the college curriculum and interact with the societies as well to provide meaningful training at the right level along the way. And these are presented in a variety of ways, depending on their level of seniority and the level of perhaps fidelity required. So if you happen to be a trainee and you're coming to the intermediate general surgical lap skills course, this is a cadaver model for teaching a trainee how to do their first TEP. And at first glance, it actually looks very authentic, and often it takes people a little while before they look at these videos and say, oh, hang on, the vessels don't seem to be pulsating. They are really very authentic models, but I have to say cadaver models are expensive. So then we go to other sorts of models around. This happens to be from an obs and gynae course. Really very, very expensive models, these ones, for a delivery of vaginal delivery with I think that's a placenta sitting over there. This is for repairs following episiotomies, and here's a central venous cannulation model, fully equipped with blood, which can be made pulsatile if we're really feeling mean. So these are elaborate, expensive models. But I have to say, we have some experience with inexpensive models, and so the this model here, I think many of you have seen the epidermoid cyst model through the ASSET course and basic surgical skills course prior to that. That used a glove finger with toothpaste, and we found it was a little less realistic than we wanted it to be. So we developed our own model at CTEC using this, which I'm not sure if you recognize it. Those of you who are paintball enthusiasts, we found that the gelatin paintball, if you put it into fatty tissue and then put it under the lights, put the tissue under the lights so it warms up a bit, the gelatin starts to soften up a bit, and it becomes a really authentic sticky model for the epidermoid cyst. And there's still a surprise if you happen to rupture it. Not the olfactory surprise that we get with epidermoid cysts, but a surprise nonetheless. Another model we've developed is a party balloon with some Mefix on it. And this then becomes a model for suprapubic catheterization. And it's actually really is very authentic, and it's a nice adjunct to one of our emergency procedures courses. We try and keep things simple. This is peg transfer, a very well recognized two-point discrimination technique in skills acquisition. Moving up the tree a bit, we've got a laparoscopic box with a portion of pig small bowel in it, teaching, I think, figure of 8 suture for a closure of an enterotomy. Really simple substrates, but they've become really useful in our armamentarium. So we've got lots of toys, we've got lots of kit, we have cadavers as well. And the question is, how does simulation training fit into surgical training? Where does it all fit, the simulation? So I think if we look at surgical training, the state of affairs for most jurisdictions, there's different realms of activity. We have some mandated simulation activities here. We have some of these hospital-based simulation activities, or ALS and ALS and CPR courses. There's some academic and scholarly activity going on over here, some professional development which may or may not be available, and of course attendance at various meetings. So this is professional behaviours which provide an adjunct to hospital-based surgical training. Add in the influence of CTEC with intermediate skills courses, advanced skills courses, and additional intermediate skills courses. This is what we have going for many of our trainees in Australia, especially Western Australia, of course, because of the ability of CTEC to host these. And thankfully, many other jurisdictions are picking up on this. So it makes the picture a little bit more fulsome, adding in the opportunity for simulation. Okay, so simulation probably on its own just isn't enough. We then need to say, well, what about assessment? And so assessment needs to take place. And this is a very simple way. It's a student rubric on basic interrupted sutures. And so we've instructed our staff, our academic staff here, that we want to introduce proficiency-based assessment into every course as we develop it. And I think it's a 5-year program at CTEC. And then we say, okay, well, technically proficient, does that equate with competence? And the answer is probably not yet. We don't have any broad agreement on competence in surgical training. Is it based on numbers of courses? Is it a time-based phenomenon? I think we would agree these are surrogate markers. And there is some data out there. This comes out of Gallagher from Ireland, Satava from the US. These are people who are champions in the surgical skills acquisition area and have tested this using proficiency-based progression models for skills acquisition and retention. And I think this is very valuable and will be adopted as time goes by. Where's the future sit though? I think simulation can have a strong role in assessment and beyond. I think our patients are less tolerant of being practiced on. We need to be wary about surrogate markers of competence. And perhaps looking at the need for proficiency-based progression and assessment in determining trainee competencies, but also, you know, this comes down to consultant revalidation as well. And of course, that really does become that fellow the elephant in the corner around this one. And that's much more discussion is required around that. I think that's probably enough for us to chew on for today. And I'd like to thank you for your attention today. Thank you very much.